to speak about the topic. I'll be talking about S1 pedicle screws. The few techniques which have been described putting an S1 pedicle screw are the open technique, the freehand technique, the fluoroscopic, and the minimal invasive technique. I'll be only concentrating over here upon is the open technique, which is a basic technique, and all people entering into spine should know about it. The first more important thing which every surgeon should know is the anatomy. If you look at the sacrum, the anterior body is usually bare. It just has a middle sacral artery which is redundant, and most of the structures are usually lateral. The neurovascular structure is more laterally placed. So the most of the screws which we intend to put are starting from here and ending up in the bare area. And the salvage screws are usually preferred in the sacral ala. I'll be going about it. So when Mirkovic did his study, so he put screws and he found that when 45 degree, they were laterally, those the salvage screws were done. So they had usually abutted the lumbosacral trunk, 10% usually abutted the sacroiliac joint, and it had 8% had internal iliac vein injury when the screws were entering here, this zone in the sacral ala. So this is the relatively the safe area. The more of the bone is usually available in the anterior part of the S1, and usually in the topmost part is the bone density is very high. So this area is usually the safe area where the screws are intended. The screws intended in the middle area should be bicortical. The screws intended as salvage technique or rescue technique should be not bicortical. So the most common techniques again are the medial, mid-sacral, most common. Laterally is the salvage technique. Two entry points have been described for the S1 pedicle screw. One is the zone 1, which where you take down the facet joint, and the zone 2-1, which is the most commonly followed or the most previous technique followed, which is given by Roy Campbell. And this was where you go 2 mm below lateral to the facet joint. The most common technique which has been described and most surgeons follow is the 2 mm lateral and below the S1 facet joint. This I do not usually use this technique. I use the osteotomy technique. I use the osteotomy technique because the osteophytes in the degenerative spine might be greater. In the males, the iliac crest is very high, so getting a medial angulation is difficult, and it is difficult to visualize this area. So I prefer my technique, or the technique which I use is I do an osteotomy of the facet joint, and I take down the superior articular process, and I use this entry as an entry point. The direction of the screw is, as described, is usually 30 degree and aims toward the sacral promontory. The usual steps is that you do a lateral exposure, you expose the facet joint completely. I do the osteotomy and you find a shiny facet joint over here. You take down, you do nibble the S1 facet joint, and with a pinhole, the awl is, I take a lateral fluoroscopy and I point it towards the sacral promontory. And I tap the Lenke probe up to the sacral promontory till it reaches the sacral promontory, and I choose a screw which is 5 mm more greater than the probe. So this is the way I do the S1 pedicle screws. There are a lot of complications. I will not be covering the complications. They will be covered by Abhishek Srivastava. So there are two techniques to summarize. One is the classical technique where you expose the facet joint and you go 2 mm inferior and lateral to the facet joint. The other technique is you do an osteotomy of the facet joint and you nibble off the facet and you do a rim entry. So this requires a more lateral exposure, and it is difficult to go laterally in males because of the higher iliac crest. In this, it's an easy technique where you do an osteotomy. This technique also allows you a bicortical purchase and gives you a wider hold, a greater hold for the pedicle screw. To summarize, Everyone should be aware what is anterior to the sacrum. The medial orientation of the sacral promontory should be known. Avoid bicortical purchase when you are putting lateral screws or the salvage screws, and use a CT scan to determine the safe trajectory and the screw length when you are doing an S1 pedicle screw also. Thank you.